So we're going to start by talking about salt and hypertension, and we will be hearing from Dr. Rajan, Ravichandran, who is director of the MIOT hospitals, chairman of the Supian's Health Foundation in Chennai. And I really want to congratulate our colleagues at Micro Labs for their willingness to allow us to discuss something as important as salt, just for our general edification and knowledge. So please, sir, if you're ready to go, we'd love to hear all about salt and hypertension.
I have permitted to add only one point. Dr. Ravichandran is involved very much in the advocacy on salt reduction. In fact, in 2014, he received an award from World Hypertension League. So that gives me an enthusiasm to put him as a speaker here.
Good evening, everybody. At the outset, I should thank Dr. Narsingan, the organizers of this symposium, Micro Lab, and World Hypertension League for having given this opportunity to talk in front of you about salt and hypertension. This topic is getting great importance, and salt, as you know, is a very ancient substance. It was discovered 7,000 years back as a preservative. So salt was used to preserve the fish. So you hunt in the summer months, keep it in the salt water, that is brine, to tide over the winter months. So it was a strong preservative, very important substance in the ancient past. The Romans considered it so important that the salary was given as salt bags. The word salt is derived from salarium in Roman. So it is a very important substance. It continues to be still the best preservative. And it is also reducing it is the most cost-effective way of reducing hypertension in the population. Unfortunately, although it was started as a preservative, now it has become a part of our integral society due to the taste that we have developed for salt. If you look at the history, the French physicians were aware of the relationship between salt and hypertension in the 19th century itself. The longest trial was conducted in 1940 by Walter Kemp, who kept persons without salt for more than a year. And he showed there was not only a drop in blood pressure, there was a reduction and reversal of the heart size and an improvement in kidney function. Looking at how salt produces hypertension. Salt is associated with water retention, expansion of the blood volume. All of us know it. The blood volume is then transmitted to the endothelium. Then normally the endothelium, the blood vessel should dilate by producing nitrous oxide, in which case the blood pressure would not go up. That is the mechanism of salt-resistant hypertension. If you give salt and if the blood pressure doesn't go up, it is salt-resistant hypertension. If on the contrary, the nitrous oxide is not produced and the blood vessel fails to dilate, you find that the blood pressure goes up. So that is salt-sensitive hypertension. Basically, this is genetically determined whether you are salt-sensitive or salt-resistant hypertension. But what starts as a salt-resistant hypertension can change with age. So this nitrous oxide production can go down. So although it is genetically determined, age, kidney function, medications can all change the sensitiveness of the blood vessels to salt. So what is the evidence? The salt is connected with hypertension. There are more than 50 studies which have shown, epidemiological studies. The most important one, I am sure all of you are aware, is the InSH study, which showed in more than 32 countries, more than 10,059 patients, males and females between 20 and 60 years, there was a direct linear relationship between systolic and diastolic blood pressure and the salt consumption, which was detected by using the 24 hours sodium measurement. Very important test to know the salt intake of a person. So that was the most important inter-salt study which showed the relationship of salt and hypertension. Obviously, there are interventional studies, genetic mechanisms which I alluded to, the salt sensitiveness to hypertension, animal experiments in chimpanzees, treatment meta-analysis, mortality studies, population studies, all attributing salt and hypertension. The South American Indian, this man is a tribal man who has no exposure to salt at all for generations. He has all the stress because of predators, because of tribal wars, but still he is never exposed to salt. His average blood pressure in the tribal is only 96/61. Cholesterol is also low. He has access only to natural food, very little meat, more of vegetables and fruits. No vascular disease. Even at he ages, he doesn't have vascular disease or hypertension. Of course, they die of infections and due to deaths due to animal bites. Chimpanzees. If you look at one of the earliest experimental studies, chimpanzees which are normally don't eat have access to salt in the jungles. Once they are urbanized and they are fed the human salt, what the humans consume, about 10 to 12 grams of salt, over months, 6 months, 14 months and 20 months, the blood pressure what starts with 100/60 lands up with 140/90. Meta-analysis. These meta-analysis studies have been there both in normotensives and in hypertensives and have shown that a reduction in salt is associated with a reduction in blood pressure. Japan was the first one. In 1960, the government of Japan took a campaign to reduce salt because Japan was having one of the highest salt consumption in 1960s of almost 18 grams a day. So from there, it was brought down to 14 grams. And with that, there was not only a drop in blood pressure, there was an 80% reduction in stroke mortality. At that time, smoking was still rampant in Japan. Finland. Finland also is one of the early countries which had a program for reduced salt intake, and they showed a reduction in diastolic blood pressure and a stroke mortality. If you look in the last couple of years, there have been a number of scientific papers which have come out. And I looked up almost 20 papers have come out in the last 2 years of correlating to salt and hypertension and reduction in stroke, cardiovascular mortality and chronic kidney disease. Of course, this has also been due to the WHO warning in 2 years back after the post-COVID that countries have gone derailed from the pathway of campaign of salt against non-communicable diseases. So even a small program like a self-performed dietary sodium reduction. So what they did in the Danish study was a telephonic conversation and for half an hour educating on reducing salt, and this was followed in one group for 4 weeks and in another group they were allowed to take the normal salt, and they could find there was a reduction in blood pressure almost to 6 millimeters with this. Community-based intervention also in hypertensive patients. Guidelines and use of promotion low salt intake in China. This was after the study where they showed the use of low sodium salt substitutes reduced the mortality of strokes. Of course, commonly used salt substitution associated with a low mortality, high salt intake linked to increased salt intake for kidney disease. Again, in China, it was shown that higher salt intake was associated with increased protein leak. The salt intake is associated with a leak of protein in the urine. This is very interesting. In our language, local language, the Tamil, salt, the word salt is used both for protein and sodium, the common salt. So patients always come and tell you that they are leaking salt in the urine. What they mean is protein leak. But China, they showed studies which showed proteinuria is linked to salt intake also. So a recent study which showed by reducing salt intake in a short period, even 2 to 4 weeks, there is a drop in blood pressure. One of my colleagues saw the advertisement. He's a professor in IIT, and he saw the advertisement of the American pistachio. for vegetarian to improve the protein intake. So he took for the next few weeks 100 grams of pistachio daily, and after 4 weeks his blood pressure went out of control. Then he realized the pistachio was all salted and he was consuming very high salt in 4 weeks. So there are adding salt to foods, hazard, premature mortality, effective treatment, several papers that have come in the last 2 years. So all of us know what is the recommendation by the WHO. 5 grams of salt from all sources. Natural salt, salt added during cooking, and salt that is present in the hidden salt that is preserved in the packed or packaged food. So I am not trying to talk about the confusion of sodium and salt, because this is important when we label for the common man. But suffice to know that 2 grams of salt is equivalent to 5 grams of common salt. Normally, the sodium is responsible for the hypertension in the salt component. But what I saw interestingly in the couple of 2 papers from China again, that chloride also has a role in hypertension. So how to bring down this salt from 12 to 5 grams? Reformulation. The mantra is reformulation. Reformulation at home. So use less salt at home. Reformulation in eating out or procurement. Government agencies which procure mass meals, there should be a reformulation. And of course, reformulation in the food industry. So reformulate to bring down the salt. Educate the public that salt added is a slow chronic poison which puts up your blood pressure and a major cause of death and disability, particularly strokes. Use less salt and salted products. Schools, communities, continuous TVs, videos, and other public campaigning. Obviously, salt added by the industry is very important, and it is gaining importance in India, although the salt intake in India has been shown to be more during cooking, but packed food is gaining importance with modern urbanization. Of course, I am not going into the details of labeling and tax on salt, etc. I run a foundation for the last 27 years, and our program from 2010 has been on reducing salt intake of the Indian population. Dr. Narsingan already alluded to the fact that we got the Notable Achievement Award by the World Hypertension League in 2014. This is a walkathon we started in the beach in 2010 in Chennai, in Pondicherry. Specifically, I am mentioning Pondicherry because this is the only state in the whole country where low sodium salt substitutes are used more because of the effort of one physician who has made it available to the population. Of course, in Trichinapalli, we have several posters where celebrities talk about salt, videos which we have released. The Vice President of the country gave a message. We have street plays which we take them to the slums. People think that the poor people don't have hypertension. Poor people consume a lot of salt and hypertension is a problem. Street plays in slums again, where we try to educate them. Of course, if we had a world international conference in 2017 when Professor McGregor from the WASH chaired the session and Soumya Swaminathan of the WHO was present. This was conducted in IIT Madras and IIT Chennai. We had the New Year resolution to avoid the salt shaker. We campaigned to the restaurants in Chennai, asked them not to keep the salt shaker on the table. See, the habit is if there is a salt shaker, if soup is served, even without tasting, people add salt to it. So now about 200 restaurants have kept the salt shaker away from the table. And of course, we had essay competition in schools, children, where they are given prizes for essays on salt, a very popular program. And of course, the World Healthy Kidney Day we celebrate again because it falls during the World Salt Week. The next week we have the World Salt Week and the World Kidney Day. And posters we released with celebrities. Again, the superstar talking on salt intake, which is a very popular video we have. And of course, we launched the Low Salter organization 2 years back, where both physicians and lay people have become members. Again, with the Directorate of Public Health, the Tamil Nadu government has been very supportive. 2,500 physicians we have interacted, and we have now the government has sent a circular for the use of avoiding salt which is not iodized and create an awareness about low salt intake. We had the workshop for physicians in IIT Chennai, as well as we have had it in Mumbai. Dr. Narsingan also took part in it. And I'll conclude with my talk. We would like to be like the chimpanzees in the wild, have a low blood pressure rather than the urbanized chimpanzees. Thank you very much.
So, Dr. Ravichandran, that was a wonderful talk, and congratulations on everything that you have done over the years and what you've achieved. So, there are three major approaches one can take to try to reduce salt. One is educating and trying to change behavior, always difficult. And in the studies, I was involved in a lot of the National Institutes of Health studies, where we had very good teams trying to work with our participants. And we could achieve in almost all of those trials about 25% reduction. You don't get as much, at least in the US, we don't get as much when we're not using those teams. So it's really important, but it's really difficult. I think we both agree on that. The second approach is policy, trying to get governments to influence the manufacturers and processors of foods not to add so much sodium. Depending on the country, that can be very valuable. It's potentially very valuable in the US, but it's almost impossible. It has proven to be very difficult to get policy changes. Some countries have been much more successful, and of course countries that don't eat too much processed foods, it doesn't work so well, but it's a good strategy. The third one I really want to quiz you on this is, you mentioned it, salt substitution. And yes, one can substitute usually up to about 25%, typically with potassium. With higher substitution, it's not very palatable, it becomes astringent. And you mentioned Finland, and in Finland they moved to salt substitute many years ago. They use pansola, and it's almost all of the salt in Finland, both for baking and the salt that is used at the table is pansola. Most other countries haven't moved as much, but you mentioned the cluster trial from China, which was a really good example of a cluster trial, 600 clusters, 300 intervention, 300 control, and showing very potent reductions in all cardiovascular outcomes and all-cause mortality. So it's a pretty good proven track record. And my question to you then is, based on cost, how practical is that? That seems to be a big focus of interest now for everyone who's involved in trying to reduce sodium as very practical and tangible means of trying to reduce sodium. So I'm wondering.
Yes, we have been interacting with physicians and public. Unfortunately, here there is first the concept of a low sodium salt substitute is not there. In the sense, they think salt alternatives like the rock salt, Himalayan pink salt are actually salt substitutes, which are not, which contain high amount of sodium. So they really don't matter. So what we talk of low sodium salt substitutes are potassium chloride, which is in India we have two types of salts available, two companies, where we find 20 or 40% of potassium chloride. As you said rightly, with 40% there is an after metallic taste. It's not been very popular. The 20%, again, the cost is 3 times the normal salt. So it's been a little difficult problem, and only couple of companies manufacture. And about our surveys showed that only 30 to 40% of the physicians are aware of low sodium salt substitutes.
Dr. Rajan, I would like to compliment you for all the work which you are doing as far as the salt substitution and low salt and the awareness among the physicians and the general public is concerned. But then I was coming to that question that commonly in our clinical practice and in our Indian scenario, the public, the villagers, they opt for the alternative salts. Means whenever you ask the patients to take little less salt, they'll start saying they are taking sendar namak, and they were saying that rock salt they will take the low salt which are available in the market. Probably they are not having a low sodium as such, and then even so the question again is how to convince them that the sendar namak and the other salts also are equally bad for taking this to reducing the salt intake.
Again, it's a matter of education. But interestingly that you pointed out, we had a discussion and programs with the Directorate of Public Health in Tamil Nadu, the government. The government had sent a circular to 2,000 primary healthcare physicians, writing to them that rock salt should not be encouraged for consumption because they can also get an iodine deficiency. Because these rock salts are not iodized. So, again, low consumption of less salt of an iodized salt is safer than taking rock salt. But to percolate low sodium salt substitutes is more difficult. That it is going to be potassium chloride. I'm sure if the cost comes down, it could make a difference. Right now it is 3 times. In India, the cost of 1 kilogram of salt is about 20 cents. So whereas the cost of a low sodium one would be 3 times. It's almost $1 or little more.
Yeah, one more question. That we all know that reducing the salt definitely reduces the morbidity and mortality, cardiovascular mortality. But then again, it's a J-shaped curve where if we reduce the salt to a very significant level, even then the low sodium also causes a little increase in morbidity and mortality. So how are we going to describe and to convince the patient that how much to take and how much not to take?
See, normally hyponatremia, what you are referring, is not seen unless the water intake is unrestricted. Normally it happens only when you take a diuretic. When you take a diuretic, the free water clearance of the kidney is affected. Otherwise, if you take water, the kidneys will remove it. It's called free water clearance. But in the absence, if the kidney function is not good, or if you are taking a diuretic and you reduce salt intake and you have access to unlimited water, your sodium will drop. You will get a hyponatremia. So it's always, you should look at the kidney function and the use of a diuretic when you are recommending a low salt, and a simultaneous water restriction may be advised.
Shashank, any comments from your side?
I think it's a great talk. I think what Dr. Soni was alluding to is sometimes very low salt can also aggravate insulin resistance. But I fully agree with you that the consumption of salt in India is so high. It's almost 5-fold than what we are supposed to have. And our biggest challenge is the invisible components where there is salt, like pickles, chutneys, papads, the foods. And I think we need to hit hard. I congratulate you for your public advocacy. I think we all are one in this movement. I'm also a big proponent of restricting salt and sodium. And I think I completely agree that what Paul was alluding to, that we need to make this and further compel our manufacturers and policymakers to restrict. Particularly, there is a free flow of foods. Particularly, people are not cooking at home. They are ordering foods from Swiggy and Zomato, which are all ultra processed, and all the ultra processed foods have very high component of salt. Preserved food is back, and that's a big, huge problem which we're having. So we have a dual jeopardy. In rural India, we have the papads, pickles, and the chutneys, and we have the foods which are there. So I think we need to continue the movement which you are doing. I congratulate you for that.
Thank you. Actually, one of the biggest problem in India is instant noodles. The instant noodles contain very high salt, and we wrote to about 300 food manufacturers trying to request them to reduce the sodium component in the manufacture. Of course, out of 300, only 2 replied. 298 did not reply. Our letters went down. But fortunately, the most important one, the Maggi noodles, they have reduced the salt. So that's been a good achievement for this country.
Thank you for the nice talk. Maybe the most important thing is to coming back to the diet of the chimpanzees. Because the problem now is the food industry. If you want to sell more, put more sodium. It is the way. Maybe it is not a good idea to recommend only restriction in sodium, but also increase the intake of potassium. That means coming back to natural foods, more vegetable, more fruits, less industrial foods. And maybe it is a good recommendation, because if the recommendation is only decrease the intake of sodium, the results is that nobody accept this recommendation. We need a lot of effort to that. Maybe if we started to recommend a healthy diet, we will have good results.
Absolutely. I think the potassium intake should be increased in natural way with fruits and vegetables. The ratio is very important.
It was a wonderful talk, sir. But what surprised me is that we generally talk about reducing or stop eating refined stuffs, whether it's white sugar or even white salt. I always thought a rock salt, which has some impurities, some minerals, even some earth content, and so many things, I'm actually surprised to get from you is that both have equal amount of salt.
Yes.
So I always thought that giving the smaller amount of any salt, which is not refined, would be better for most of the people. That was, I wanted more clarification from you.
What he said is that sodium content, which is the culprit.
Yes.
Sodium content.
They are
is
similar.
Quite similar in rock salt as well as in the commercial.
Including Senda Namak, Hindu
That's
Poo,
right. That's
all
right.
different so-called salt alternates, I would say,
And
available
that is-
in India.
that is
They are
why-
not salt substitutes.
That is why the quantity is a little more, and that's why these are equally bad. Yes, sir.
Sir, wonderful presentation. Sir, when a normal serum sodium of 145 milliequivalents, the kidney excretes around 1.5 kg of salt per day. That is 25,000 millimoles of salt per day. If you take excess salt, will the salt itself damage the kidney other than producing hypertension, volume overload, heart
Yes.
diseases? Will salt itself deposition in the kidney, will it damage?
It is not a salt deposition, I would say. Salt is known to produce endothelial dysfunction. That's the reason for this vascular damage. See, this is again a point which is very important, which people do not realize, that I have a normal blood pressure. Why should I restrict salt? The moment I tell a patient, you require to reduce your salt, they say, I don't have blood pressure. So it's not that you require a high blood pressure to reduce salt, because salt produces endothelial damage. And you know, the maximum endothelium is present in the glomeruli. So the kidney has the largest endothelial surface. So you find if you take high salt, proteinuria increases and there is a damage to the kidneys.
Thank you very much, sir.
Question probably. After that,
Recently, I read an article by a nephrologist in India. It says that regarding the salt substitutes which are being marketed, not everything has sufficient quantity of the potassium. That's 20 or 25%. There's a wide variability in that, and that needs standardization if the salt substitute has to actually work. Can you please enlighten?
So as I said, salt substitutes that are available in the country are only 4 or 5 brands. And I don't want to name, but they are leading brands like Tata's and ITC, etc. So, and they claim a salt content of potassium content of 20 to 40%. So the regular brands are okay. But if you are going to buy some salt substitutes in a smaller places which are not branded, I'm sure you have to be careful on the potassium content, which could be variable.
I think it was a wonderful talk given by Dr. Rajan, as well as a wonderful discussion by the participants. All the audience also, they had a very good participation. Thank you very much, Dr. Rajan. Just give
Thank
a
you.
big hand.
I think after listening to Dr. Rajan Ravichandran and the expert comments by Dr. Shashank Joshi, many of you, I presume that you will not take salty food this night. Totally avoid poppers, appalams, and then pickles and all those stuffs. And I'm sure you will not add salt to your soup also. Okay, having listened to this excellent lecture, thank you very much, moderators.